So it is Thursday, June 25th, and today I would like to talk about men's health, and we can take some questions at the end as they come up. So some of the common topics in men's health that we deal with, number one, male hypogonadism, and for purposes of this, it will be testosterone deficiency, but I will talk through that. Erectile dysfunction is relatively common, benign prostatic hyperplasia, and of course, prostate cancer, which I think is on the minds of many people that when we think about men's health topics. Male hypogonadism, so hypo meaning low function, basically involves low testicular function. So it's related to sperm and testosterone production. Hypogonadism as an umbrella is a decrease in one or both of the above. Primary hypogonadism really is focused more around a disease and dysfunction of the testes, whereas secondary is disease and dysfunction of the hypothalamus and pituitary. So primary being at the source of where hormones and in this case sperm are produced, whereas secondary are other factors that are causing a decrease in one or both of those. So when we look at, and this is termed a simplified look at adult male hormones, and simplified from the standpoint of me as a functional medicine provider being educated. So it's probably not super simple for everybody. But, we do have our hypothalamus, this is in our brain, and our anterior pituitary. And basically we have gonadotropic releasing hormone. We have different hormones that basically cause a feedback loop. So different things get, basically the gonadotropic releasing hormone instructs the anterior pituitary to release hormones, which then basically travel essentially to the testes and signal, hey, produce more of this or slow down production. And so there are feedback loops. And we have the same thing in women's hormones, thyroid. I've talked to some of you about in this same sort of feedback loop. And so what I want people really to gain from this slide is that there's a feedback loop. And so when we're talking about primary, you're talking about a problem or dysfunction here. Secondary, when you're starting to look at that, is maybe there's a dysfunction here relating to these things being the reason why this isn't working, and the primary problem not necessarily being at the testicular level. So you can see, like, basically FSH gets related to sperm maturation and production. LH is something we look at when we're looking at testosterone deficiency as well, but that stimulates these Leydig cells in the testes to produce testosterone. So, and not dissimilar to women and looking at basically fertility, men begin life with lots and lots of Leydig cells, but they start to lose them as they age, kind of like women, our fertility decreases as we age. So there's a lot going on here, but I just want people to get an idea. So I think most of you know I like visuals, and because I just think it's really helpful to kind of go, oh, okay, I can kind of see what that feedback loop means. So when we look at clinical features of hypogonadism, we do look at this from an age and time of onset. Certainly if we see in utero, so when this baby is growing, testosterone deficiency there can definitely result in anatomical changes, changes in fertility for that person, whether you're dealing with maybe an undescended testes. It's not real common, but some of the genetic things that can happen where basically some of those secondary sex characteristics and even maybe the penis is underdeveloped, some of those things can happen. That's with in utero testosterone deficiency. We don't see those a lot, but we do see them. Prepubertal, that results in the failure of boys going through puberty, and those guys will appear younger. Some don't develop the facial hair, sexual, pubic hair, so they have smaller genitalia, struggle with gaining muscle mass. If we're dealing with hypogonadism as an adult, and more often than not, this is, with aging, but that being said, we see this earlier on, but then men are often reporting decrease in energy, libido, they're having depression, longer term impact on fertility as well. We're seeing issues with that, sexual hair loss, muscle mass loss, and as well as loss of bone density. So men can have osteoporosis as well. And so lots of different features, but really kind of depends when we see things, what the impact of low testosterone and low gonadal function will determine what happens. So primary, as I've already discussed, that more commonly it results in decreased sperm production versus testosterone production. When we talk about secondary, it's often a bit the other way or a little bit more of both. Primary hypogonadism, when this happens initially and often at younger ages, more of them can have gynecomastia, which is breast development in men. Some of the congenital causes of this would be FSH and LH receptor abnormalities. If we go back to that previous slide, undescended testes, acquired things that will impact testicular really function in the testes is infections like mumps, certainly radiation if somebody has had cancer. There are different drugs, and a lot of these particularly are related kind of chemotherapeutic agents. So primary doesn't have to be just at, maybe at birth and at a young age. Toxins, certainly trauma, liver disease, kidney disease will also potentially cause problems with this as well. When we look at secondary hypogonadism, that tends to involve a decrease in both sperm and testosterone. There are some congenital causes. We can have growth hormone deficiencies. We'll talk a little bit about leptin, and that is something that I've spoken with some of you about before, but that's basically one of our hormones that tells us satiety, but that actually is related to testosterone and steroid production. Also, we can have issues again with that luteinizing hormone and the follicle stimulating hormone as well, the LH and FSH, as well as pituitary abnormalities, because that's where the GnRH that is going to make a difference. So if there's a problem with the pituitary, you may not be able to produce some of those other chemicals that we need for signaling. Acquired causes of secondary hypogonadism, disease and trauma to both the hypothalamus and pituitary. So we're impacting that feedback loop. When we have issues with gonadotropin suppression, there can be elevated prolactin. There are different drugs that we use, particularly in prostate cancer, that are GnRH drugs, and those are given at that time to actually really shut down testosterone production. When we look at gonadal steroids, that's often we're dealing with people who are using anabolic steroids. If people are using steroids because they're lifting weights, those kind of things. And I have seen people really shut down their normal testosterone function by using gonadal steroids, to promote muscle mass. Another thing that can happen is long-term glucocorticoids. So that would be somebody who's maybe on prednisone for emphysema or COPD, or for arthritis. Opiates are another common cause, and I think this is under-recognized or often undertreated. So people who are on chronic pain medication can have testosterone dysfunction and low testosterone because of that. certainly critical illness, chronic illnesses, diabetes. Obesity is really actually a pretty big one in terms of low testosterone function. It's a very, between diabetes and obesity, it's a pretty primary driver right now with what we're seeing. Sleep apnea also is a disruptor in terms of testosterone production and secretion. Other acquired causes would be damage to these gonadotroph cells. And so we think about tumors and infiltrative disease. Sarcoid would be one of those. Another thing that is probably more common than we've thought is hemochromatosis, and that's basically an iron overload disease. And that is something that's on my radar more. Like I think I'm looking for it more, but I'm also seeing it more, and that can be one of the things that can also play a role in low testosterone. Infections like meningitis, traumatic brain injuries, that again could disrupt that hypothalamus and pituitary. And then there's this whole category of idiopathic, which means we don't know. Well, we don't know. And I think in the past, and we still hear, certainly in conventional medicine, like you can go in and see somebody and they're like, oh, that's idiopathic. Well, okay. I mean, I know in the past I would say the same thing, and I may still say the same thing right now, but rather than like just end it with we don't know, you know, I usually push more why is that. So one of these things that we know, and there's different classifications, and there is a European Society for Adrenal Function, and one of the terms that they're utilizing is adult onset hypogonadism, and that is part of this secondary group, and it's this without medical causation. And what we're learning is that probably a lot of that really is that whole diabetes and obesity, those things playing a role in this. So maybe our I don't know is more a lack of understanding of some of the mechanisms with which those specific diseases can disrupt testosterone production and function. So the prevalence of low testosterone, and this was in 2014. So clearly this is older data, but for ages 45 to 54, 34% of men will have low testosterone, which is not insignificant. 55 to 64, 40%, 65 to 74, 40%, ages 75 to 84, 45.5%, 80 plus, 50%. So overall in men, 38.7% prevalence of low testosterone. And that's very significant, and I think often goes under-recognized, really. And you'll see, number one, I kind of alluded to this already, low testosterone is associated with cardiometabolic disease. And in recent years, this is another study, recent years have seen a substantial and as yet unrecognized age-independent population level decrease in testosterone in American men, potentially attributable to birth cohort differences or to health or environmental effects not captured. So I think what we're seeing, a lot of it is to environmental issues, and it's diets, and and there's lots of estrogen mimicking things that could be causing issues. BPA plastics are disruptive of testosterone as well. So there's a lot of things playing a role in this. So the fact that this prevalence is so high is really quite significant. I wanted to throw in a slide, about the role of basically marijuana and phytocannabinoids. And so this is basically a summary. It was a review article, and you can see we talked a little bit about the FSH and the LH. So those are some of those gonadotropic hormones that are feeding, but you can see like FSH, it looks like probably maybe not much effect. One study showed it definitely decreased that. LH decreased in 2 of the studies, equivocal effect in one study. In testosterone, 2 studies with even acute marijuana use and chronic marijuana use showed a decline in testosterone. Others have been more equivocal. So there's definitely some likely impact there. And I mean, I guess this is on my radar because, it's legal in this country right now, or in our state. And, certainly there's some cases where probably using marijuana versus maybe an opiate might be better, but we also have to understand some of the other systemic impact of marijuana, because I think people think, it's psychoactive, but we don't always think about some of these other impacts, and especially for men and women if it's really impacting our hormones as well. So clinical features of testosterone deficiency, when we start to look at things, there's increase in abdominal fat, hair becomes thinner, more urinating at night, which is related to the prostate, decreased interest in sex, sexual performance decreased, and really like depression, lack of zest for life, we can see in some men. Testosterone can decline 0.3 to 1.5% per year starting between age 25 and 35. Certainly comorbidity, so when you're talking about obesity, chronic illness, diabetes, sleep apnea, those things contribute to this. But of note, it doesn't happen in all men. So, statistically right now we're thinking about, 38, 39% of men. Another key factor is there is a component in our blood that is used in our transport, and that's sex hormone binding globulin. And sex hormone binding globulin levels rise with age. And essentially what that means is more of the testosterone gets tied up by this sex hormone binding globulin. So there's less free testosterone, so relative testosterone deficiency. Obese males age 14 to 20 have up to 50% less testosterone. So I think that is playing a role in this. I wasn't able to find something with newer data, but I would be really curious if our prevalence is higher now than it was in 2014, because certainly obesity rates have risen in our country. Men with a BMI or a body mass index over 30 have triple the risk of having low T and sexual symptoms. And, we know obesity plays a role. And so if somebody is having trouble with low testosterone, some of the, feeling the lack of energy and increase in abdominal fat, but also having sexual symptoms, whether it be erectile dysfunction or decreased stamina. I often say, one thing is if a man is to look down, if they can't look straight down and see their penis because their belly is in the way, that belly is very likely to be a significant part of the problem. So, and that's something easily that men can gauge on their own, and they don't need to go to, any provider to be able to make that assessment first. In terms of lab testing, when we're looking at this, we look at free and total testosterone. Ideally, we like to measure it in the morning because that's when you should have levels at the highest. Average is 300 to 800 nanograms per deciliter. The blood test, the lab reference ranges are age adjusted to reflect anticipated reduction in testosterone production. And so there's some issues definitely with that. In terms of anticipating reduction. And the question would be should we really be anticipating this reduction? And we do, but is that a normal thing or not? And I think that there's lots of questions there, because certainly over time, more and more men have low testosterone. So over time, are we lowering ranges and changing our anticipation? So that is definitely a question. The LH and FSH helps determine between that primary and secondary. So if the testosterone is low and these values are high, then it's primary failure, because you have this feedback down to the to the testicles saying produce, 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 but no testosterone or low testosterone is coming out or low sperm production is coming out, then we know that that's a primary issue. If the testosterone is low and the FSH and LH are normal or low, then we start thinking about secondary causes for the low testosterone. Here again is the sex hormone binding globulin, and it binds testosterone. It's a transporter. It gets increased with age, with an overactive or hyperthyroid, liver disease, HIV. There's anti-seizure medications will cause that, and high estrogen will increase sex hormone binding globulin. And so you can see when we think about these things and these causes, then we can start to think about how can we improve things. Decreased. Interestingly, I'm not going to encourage somebody to become more obese and insulin resistant, have diabetes, to decrease the sex hormone binding globulin. That wouldn't achieve a long-term goal, really. Excess growth hormone, though, kidney disease, and synthetic progesterone can cause decreases. The other labs that I look at are cortisol and thyroid function, a blood count, metabolic panel, cholesterol levels, iron levels. And one thing I just realized that it's not on here is vitamin D. And vitamin D actually plays a significant role in testosterone production as well. And we know that if we can get vitamin D levels up, at least above 30, goal above 50, we can actually, that independently will help increase testosterone levels. And I'll talk more about that. And I've got a study cited in the references. So how do I think about this? There's a mnemonic that I use when thinking about this, and this is how I was taught by the Institute for Functional Medicine, and we use this with all hormones, really. So it's called PTSD, and so I really think about production. So is there an issue with production or synthesis or secretion of the hormone? Transport, is there an issue with transport, being able to convert it, interaction, distribution of testosterone in the body? Sensitivity, so like, is there some issue that maybe those cells aren't as sensitive to the hormone, whether it be the testicles or cells that we need testosterone acting on? And then detox and excretion. So this is just to give you just a little bit of an idea of like, this is how I am thinking about these things, rather than just like, oh, your testosterone's low, you need testosterone. Well, there's a lot of ways we can think about this. Variables related to these testosterone levels. We talked about the sex hormone binding globulin, and if you scroll back and forth between these, you're going to see some overlap and some things that seem conflicting. So what inhibits testosterone levels? Obesity. Stress and cortisol does. High insulin. Inflammation, which goes along with high insulin and obesity. Excess alcohol. Zinc deficiency plays a big role in this. Leptin, this is our satiety signal. It gets secreted from fat cells, and I'll talk a little bit about leptin resistance. Aging, cholesterol-lowering drugs, because I think I put a slide in here too of the steroidogenic pathway that you can see, like, if we really, really, really are working on lowering your cholesterol, say because of cardiovascular disease, we have to be careful because we're going to lower your testosterone as well, because testosterone is made from cholesterol. Elevated estrogen to testosterone levels. There's actually a relative estrogen dominance that can happen in men, just like it can in women. What are promoters of testosterone, promoting healthy testosterone levels? Weight loss. Intermittent fasting is really a great way to improve testosterone levels. Meditation, interestingly, there are studies that just show meditation will improve testosterone levels. Exercise, we know, will. Moderate intensity exercise, high intensity interval training will improve. Vitamins A, D, and E, zinc and selenium. So lots of different factors we can work on to address when we're looking at testosterone levels. So here's a little bit more about leptin, and I think what's super important here is these feedback loops, the role of leptin. You can see, so in the center here is visceral adipocytes. So this is fat. This is fat that's around all of our organs in our belly. And so when we have more fat, we have more fat causes more leptin, so an increased fat mass. So it also causes insulin resistance. But when we have this increased fat mass, the idea for leptin is to be able to signal to your brain, if it's working normally, hey, I'm full. I don't need any more food. I don't need more energy. Well, what happens is if we get too much leptin in our system being produced by fat, we can also get leptin resistance. So basically our brain's not reading that signal right. It's kind of like insulin resistance, that like our muscles and our cells aren't responding to the insulin, so people get high glucose and develop diabetes. Same things happen with leptin. Interesting, when that happens with leptin, leptin directly inhibits testosterone production. So the more fat we create, the more likely we are to get insulin resistant, which causes an issue. The more likely we're going to become leptin resistant and then inhibit our own testosterone production. So it's all related. The other thing that happens is fat cells basically are producers of aromatizing enzymes. And what that does is takes what testosterone is in the system and converts it to estradiol. So now we have that estrogen dominance. So really, the key take home from this is like obesity, and especially that like belly obesity, really, really negatively impacts our testosterone production. It is inflammatory. It increases diabetes risk, and it just feeds back on itself, unfortunately. So when we can impact this, it's really, really significant in helping people impact testosterone deficiency. So here's that pathway. And the biggest thing, I don't want people to get lost in the weeds in this because this is a big chart. But for a lot of you, if I've talked to you about hormones, whether you're men or women, like some of you have seen this, the key to understand in here is cholesterol is up here. Without cholesterol, we don't get any of the rest of these things. We can't produce cortisol. We can't produce DHEA. We can't produce testosterone. We're not producing our estrogens. So the key takeaway here is cholesterol is not a bad thing. It's not. And it's been vilified because of cardiometabolic disease and because of cardiovascular disease. But very simply, you can see here, we have to have cholesterol. So anybody whose total cholesterol is below 150 for a total cholesterol, that's definitely going to impact your hormones. So that's the most important thing I want people to understand. So summary of some things that you can do to support testosterone levels, diet and nutrition wise. Healthy fats, so omega-3 fatty acids. So that's our fish or salmon, fish oil, avocado, olive oil, nuts, seeds, actually particularly pumpkin seeds. Getting adequate lean protein is really important. Too low a protein is not going to help us support that testosterone production. Lots of fruits and vegetables. Think about color. Red, orange, and green in particular are really helpful. Low glycemic, meaning limit simple carbs. And cruciferous vegetables, those are broccoli, cauliflower, kale, cabbage, Brussels sprouts. All of those things are really great because they actually help reduce estrogen. Pumpkin seeds, as I mentioned, and the spice fenugreek can be very helpful. We really want to focus on limiting or avoiding non-organic dairy and meats, sugar, excess saturated fats. So that's not good. Some saturated fat is fine, but lots of it's probably not so good. Trans fats, those are in processed packaged foods. They're probably in the French fries from McDonald's or any other fast food restaurant. Processed meat, so cold cuts, that kind of stuff, not so good. More than a couple of drinks a day for a man, it's going to impact your testosterone levels. Lots of caffeine can impact that negatively too, and that will impact it via impacting your sleep as well. Intermittent fasting, super helpful. 12 to 16-hour fast between dinner and breakfast the following morning or day. That we have studies that have shown independently that that helps. In terms of movement, moderate intensity, high intensity interval training, strength training, all really helpful, will definitely boost testosterone levels. Sleep, goal is to get 7 to 8 hours of sleep at night. We know that people with sleep apnea have issues with low testosterone. It's actually really important when we're working somebody up for low testosterone to actually make sure we do a sleep study, because if we give somebody testosterone that has sleep apnea, we can worsen that. Stress reduction, super important. Meditation, prayer, being out in nature, really helpful. Supplements, vitamins A, D, E, zinc, selenium, really helpful. Sometimes we utilize DHEA as an upstream supporter. Some particular botanicals, and there I have a reference at the end to the botanicals that can help support testosterone, and that would be ashwagandha, mucuna, and black seeds, which are Nigella sativa. Those are really helpful in supporting testosterone levels. So references, you can see I did put in some references. Basically, these slides people don't really have access to unless you're part of the Institute for Functional Medicine, but if anybody wants something specifically, I can help answer questions. Testosterone concentrations in pubertal males, testosterone deficiency. This is the study where the prevalence came from, and this was from Canada. Interesting on neuroendocrine aging in men, and there's been some talk on and off about andropause, kind of being synonymous with like menopause for women, and that you hear about once in a while. And then the study about the population decline in serum testosterone levels in men. And with that, I want to go back one. And when we talk about movement, a couple of things. So HIIT training, there's a lot of simple apps out. There's something called 7. And if you go, even if you Google HIIT training, you'll see there's lots of simple 20-minute routines that have you do jumping jacks for 20 seconds, rest for 10 seconds, or squats, do as many as you can in a minute. So there's lots of different stuff out there, and you can really kind of pick the amount of time that you want to use with this. And strength training, I really like to think about doing something with your lower body. So maybe squats, lunges, and then something from an upper body standpoint, some sort of a pushing and some sort of a pulling, whether it be a lat pull down, whether it be a row exercise, something like that. So those are simple ways to look at those. When it comes to moderate intensity activity, if you enjoy walking, biking, running, rowing, those kind of things, what I would say is really think about warming up a little bit, and then basically do little pickups, whether it's 30 seconds or a minute, and then rest for a minute, do it again and work up to doing like 10 little pickups. So these intensity, the intensity sessions don't have to be real long. The whole exercise and activity session doesn't have to be a long period of time if you throw a little bit of intensity in there. And that's kind of, we talked a little bit, for those of you that saw the other talk, when we talked about movement and in supporting the immune system, the goal and recommendations are 150 minutes of exercise a week. If you add intensity to it, you can actually get away with probably 75 to 150 minutes when you're adding exercise, more intense exercise with that. So that's basically what I wanted to summarize a little bit more on movement, and I'll put a link when I write a blog, and maybe on the YouTube, I'll put a link to the other exercise and movement talk that I had given a couple weeks ago. So with that, I think we're good. And if anybody anybody's got any questions, I'll be happy to field them.